warm welcome to this edition of In the Loop, the podcast where we explore the big questions facing the NHS and care system and link up with leaders and policy analysts who have to find answers, at least to some of the questions that plague these life and death public services. I'm Neil Dixon. My career has been as a journalist and broadcaster and then as leader of the NHS Confederation, General Medical Council and the King's Fund. And my co-conspirator is the ever-present and ever-opinionated Roy Lilly, former NHS leader and leading blogger. Roy.
Hello, Neil. Good to see you.
Our guest today is Dr. Chalotte Refsum, the Director of Health Policy at the Tony Blair Institute for Global Change. Chalotte qualified in 2009 as a doctor and worked as a GP in the NHS for 8 years, also working as a global health executive for the consulting firm KPMG before taking up her current role. Her area of expertise is data, digital, tech and AI, and how innovation in these areas can transform our healthcare system and, more importantly, our health. Chalotte has worked in 25 countries to support the transformation of healthcare systems globally. She was involved in aspects of the Labour government's recent 10-year plan. She's a strong advocate for universal digital health records and for AI, data and digital tools to move us from treatment to prevention and towards integrated care. And she sees the new tech revolution not just as being more tools to improve the old system, but as an opportunity to rethink the system itself. Now, Tony Blair remains a controversial figure, most notably around the Iraq War, though many in the NHS defend his period in office for the improvements to the health service during those 10 years. His institute is also not without controversy for its funding and how that affects its claimed impartiality. Its close links to tech billionaire Larry Ellison and his charitable foundation, as well as its work with countries with dubious human rights records. Roy, I hope our main engagement here will be with Charlotte's take on the NHS as it is now, but perhaps we should begin by letting her answer the question of the Institute's claim to be impartial.
I think that's very important. We should just ask the question. To be honest, I'm not bothered one way or the other whether it's impartial or not. I mean, not all of these think tanks have to be funded somehow or other. I just think we've got to be grown up and sensible about it. But, I mean, the Ellison thing does come with a bit of you have to kind of hold your nose. So, I mean, I think we should give her the opportunity to tell her side of the story.
I mean, there are two aspects. There's one is, I guess, how she views the government's attempt to try and turn the NHS around with not very much money. The other is what part tech will play in all this. And you get some people at one extreme, and I think Chalotte is probably near this extreme, who believe tech is going to be a really significant factor in terms of how we move our health and care system on. And others who say, well, yeah, it doesn't really work all that well. It's not going to have a big influence. It's still a human business, and we're going to be in that human business for the foreseeable future.
I mean, I've written for years about the impact tech should have, and it never has. Of course, I think that AI could rip out the administrative part of the NHS. And of course, I think if we use barcodes and all the other bits and pieces that Amazon use, we could speed patients through the system and have the admin cost per patient down to almost nothing. And of course, I think it's a good idea to have a decision support for doctors available on tap at the bedside. But how are we going to do it? But at the end of the day, someone's got to get a shovel and a hammer and a nail and make stuff happen. And that's what they never do.
You said that it hadn't made any difference. I mean, obviously it has transformed the way we bank, the way we shop, all those things, all those worlds have changed. And some aspects of healthcare has changed and looked like changing with the NHS app, with the development of genomics, the speeding up of new drugs and the finding of new chemicals and new ways of doing things. Those could make a real difference. And I mean, it may be that bureaucracy will stop some or all of them. I think it's very unlikely to stop all of them.
Look, I don't want you to think I'm a complete Luddite. Certainly in pharmaceuticals, I mean, the AI, of course, there are elements of it and it's in use now. There's loads of stuff we could do, but I still don't know how are we going to do it? Where is the implementation strategy? You can have all the strategies you like, but you need an implementation strategy. How do you take a bog standard hospital? How do we take that hospital and turn it into some AI-supported, machine-learned citadel of everything that's whizzy and technical and bobble hat. How do we help them do that? What have we got to do? Effectively, we've got to stop them doing what they're doing now and start on Monday with doing something completely different. Because if you look at even electronic health records that have been implemented in the NHS, some of them have been a disaster, and we can't even implement that. So I think the research should be in not what AI can do for us. We know it can do everything. But how do we make that happen? That's where the research needs to be.
I think the how question is definitely one we will want to explore. I think it's a fair point to say that if you went in 1948 along to see your general practitioner, you wouldn't necessarily see an awful lot that was different if you went to see a GP practice.
No, absolutely.
I mean, that's not fair in some ways because, of course, the things that they can do, the knowledge they have, the misdiagnosis really didn't matter then because they didn't actually have the means of dealing with it, whereas the misdiagnosis now can be extremely dangerous. But there is something around that. So I guess in 10, 15, 20 years' time, how different will it look? How different will it be in terms of the people? And your question, which I'm sure we should focus on, as well as understanding what Chalotte thinks is possible, even if she thinks it's possible, how will it be achieved?
Why don't we ask her?
Well, welcome, Chalotte. Thank you for joining us in the loop.
Thank you, Neil.
Now, we want to explore your views today on the future of the NHS, chances of recovery, how the government's doing, and also your view as a champion of tech on the potential of this next revolution, or whatever we call it, to change fundamentally the way health and care services are delivered. But before that, can we just briefly ask about the Tony Blair Institute, which has come in for some criticism for having conflicts of interest, that you're too close to tech billionaires such as Larry Ellison, and that you're too close to the private sector generally, as well as some not very nice governments such as Saudi Arabia. Just give us your take on that, having obviously thought about this before you joined the Institute.
I guess the first thing to say is that we've got about nearly 1,000 people. We work in about 45 countries. They tend to be, but not exclusively, low and middle income countries. And in each of those countries, we have a country director and a small team under them, and they provide advisory services to governments. And they advise across a range of functions. It could be health, it could be economics, it could be climate. But that's the consultancy part of our business. And it's a not-for-profit. So that's the part of the business that does consultancy. I sit in a part of the business that's called policy and politics. So we do a lot of thought leadership that comes out of the Institute. So that's the stuff that you probably know us best for, especially in health. And then we do also hold some professional relationships with big tech companies. They provide some funding. So there's well-known relationship with Oracle and Larry Ellison. But there are others. We have working relationships with other organisations that help us deliver projects in different countries. So that's what we do. I guess, how do I feel about our relationships with those governments, with those organisations? Well, I personally, I've never felt under any pressure to write anything or to hold a view because of our relationships within the Institute. We always maintain complete editorial independence over everything we write. And I think actually we've fought hard to maintain that. And that's one of the reasons that we have such a credible voice over a lot of different areas, including over health. So yes, I did think about it before I joined, but since I've joined, I've been incredibly reassured about the integrity of those relationships.
Do you have personal contact with Tony Blair himself? How much interest does he take in all this?
He takes a very strong interest. You've caught me after I've just had an hour-long meeting with him and 5 of the other policy directors. We tend to meet with him every 6 weeks and get his thoughts on our policy papers and our direction. So still very heavily involved.
I'm interested in you, Chalotte, because for a lot of people, you had the dream job, didn't you? You were a doctor. I mean, why did being a doctor suddenly not become it?
I was a GP and there were lots of aspects of the job that I loved. Honestly, it's an honour to sit in a room and have someone walk into your room every 10 minutes and tell you their deepest fears and ask you for their help. And that's a really special relationship. But I did feel that I was working in a kind of antediluvian system. I was practicing medicine in a converted bedroom in a semi-detached house in a suburb of southeast London with no access to bloods or ECGs or x-rays or anything. I just felt like it wasn't set up to manage what it needed to. And I spent half of my time feeling massively overqualified, thinking, God, you don't need 10 years medical training to deal with this. And the other half of my time feeling massively underqualified, thinking, God, you don't need me. Actually, you need a geriatrician and a cardiologist and a renal specialist, preferably all in the same room. And I just felt that model of GP hadn't changed since the inception of the NHS, if not before. You get 10 minutes to talk about one problem. You have a piece of paper on the wall saying you can only talk about one problem in this age of comorbidities. It just wasn't working for me. And then the opportunity came to do one of these clinical fellowships. I went to go and work with Bruce Keogh when he was at NHS England. And I spent half my time with him and then the other half of my time at the Health Select Committee when Sarah Wollaston was the chair. It just turned my head and I qualified as a GP. But soon after, I went to go and work for KPMG, where I was there for 6 years in their global health team. Then I came here.
I mean, how do you feel about the junior doctors now, or the resident doctors, and they're striking and all that? I mean, I suppose really you'll have a sympathy for them.
I do have a sympathy because I think the system that they're working in often doesn't value their skills, and I think their pay has been eroded over such a long time. I just think a lot of the reasons why we went into medicine originally have been lost. People went in because they thought they were going to earn a lot of money and they thought they were going to get a lot of respect and that they could walk away with a warm, fuzzy feeling at the end of the day. And I think a lot of those things have gone. Actually, you can be a doctor and you can't afford to buy a house. People come in and they don't necessarily respect your opinion because they've looked it up on Google or ChatGPT or whatever. Previously, people either got cured or they died. But now there's a lot of managing decline. And I think that's quite difficult as well. So I think a lot of the reasons why we went into medicine have been eroded. That's not to say that I don't think there's a lot of hope and opportunities for the future. It can be a bit of an nadir at the moment. And I do feel for junior doctors and what they're going through.
Thank you for that. And we should now focus on the real reason we got you here. But I was just curious. You've given such an interesting answer, and thank you for being so frank.
Okay, and we will come back to the profession. But I wonder if we start on the 10-year plan, which you were involved with. Is it a good plan?
I think it's a really good plan. I think it sets a really good vision and an ambition for where we want to take the health service. But then, as everybody has been saying, it's about implementation. And then there's also difference between here and now and then, the 3-year plan and the 10-year plan. So I think it was the right thing to do. I think it needed to be done, set out that vision. But the focus now is on how you achieve it. The idea that you can cast your mind 10 years hence and understand what technology is going to be available and then turn around and say, this is what we need to do. The fundamental thing I think it needed to get across was how you retain an NHS that is agile enough to adopt new innovation as it emerges and to maintain its financial sustainability. And if we can do that, that's the challenge, because we're about to enter an age where these new innovations and technologies are emerging and the pace at which they emerge will accelerate. And then how do you accommodate that? And I think a really good example is these GLP-1s, right? NICE had a look at this. And they decided that GLP-1s were brilliant and they represented huge value for money and that we needed to roll them out for millions over the next 3 to 5 years. And NHS England just pulled the ripcord and said we can't afford it. And it poses a fundamental question. If you have a health service that is so rigid that all you can do is add to the bill, but at what point do you turn around and say, so GLP-1s arrive and you go, these are great, but we've already spending 200 billion a year. We can't afford them. But what would be nice is if you could say, actually, these GLPs represent far better value for money to quite a lot of the other stuff that we're doing. Why can't we reconfigure the offer to citizens to incorporate these new innovations? And that challenge will come again and again and again.
You decommission.
I do think you have to decommission some stuff, or at least take a view, like getting the best value for your money for that 200 billion. Is it spending it on what we're currently spending it on, or is it reconfiguring how we spend it?
Do you think overall that there is enough money in both revenue and capital to deliver what is required, even if you get more efficient as you go forward with all this? Is it the case that there is enough revenue and capital to deliver what is required over the next 10 years?
It will never, ever be enough. But the point is, 10% of GDP is about right for a developed country, isn't it? And so I think there comes a point in which you say, you can't keep going back to Parliament and asking for more money. Like, look at the last comprehensive spending review. At the same time as they were chucking billions more at the NHS, they were getting defeated by their backbenchers on welfare reforms. Health spending has been going up faster than GDP for a long time, and it's consuming an ever greater proportion of government expenditure. And that was fine when we had money and we sucked it all out of defence and all these other areas. But now we're starting to realise that actually we might want to put a bit more into defence, and actually we're not spending enough on schools and we're not spending enough on these other things. Can't keep prioritising health. I mean, it is important, but it's not everything.
You can't not prioritise health. Listen, this room has grown dark because there is an elephant that's walked in, blocking the light from the window. And the elephant in the room is, are we saying, if you want these fat-busting drugs, you can get them from the NHS. We'll give you some element of clinical supervision, but you know what? It's going to cost you £70 a month.
Well, we've already said that in our paper. So,
I know.
But I would.
I want to make you say it again.
I would means test it. So I would say if you're eligible for free prescriptions, then you can get it for free.
No, that's 83% of the population get free prescriptions. That doesn't work at all. You've got to come up with a better idea.
Okay. If you're going to steadfastly say we want everything to be free, then you have to determine, like, what is it that's free? What does the NHS do and what does it not do? Or you say you can have more, but some people you have to pay a little bit for it. I don't know if I'm explaining myself very well.
Supposing you said, if you qualify clinically for this, and you're prepared to pay half the cost because the NHS can't afford to do it all, we'll give you a tax break on that. So nobody has to actually come up with any cash. And the government doesn't have to recycle the money or what have you. You just give them a new tax code, a fat gets tax code, and everybody pays a bit less tax for 3 months while they're on the jab.
So we didn't look at that. The way we framed it in the paper was that it's all very well saying there's good value for money, but if you can't afford it, you can't afford it. So how can you look at different ways to afford it? So we looked at ways that this extra cost could be shared between people that are going to benefit from it. So individuals benefit from it, employers benefit from it, the NHS is going to benefit from it, Department of Welfare might benefit from it if more people are in work. So we looked at different ways that you could share it. You could do price negotiations with pharma. You can do outcomes-based contracts with the providers. You ask Boots to prescribe it and only pay them if people lose weight and keep it off and get back into work. There are different ways of sharing the cost. It's all very well saying it's value for money, but then you have to work out how you're going to pay for it as well.
Then the next question then is, okay, let's say we do some deal. We bust the 1948 Act and we have co-payments. There are co-payments now for some high-end cancer products. What do you do then when a young middle-aged man comes hobbling into the surgery and he's done his Achilles tendon because he's a lunatic and plays squash 3 times a week? You're going to have to pay the cost of the operation, because if you hadn't played squash, you wouldn't have ruptured your Achilles tendon. Why can't you be sensible like the rest of us and not do that? You see, you open a door.
But I've never advocated for denying people things based on whether it's their fault or not. We've been thinking about ways that you can determine what the NHS is and isn't there for. How do you define the value of the basket of goods for which you're eligible for? And by the way, other countries do that. So if you look at the Netherlands or Israel or any of these other countries, Singapore, they determine what the state pays for and what you're responsible to pay for yourself. Actually, we already have a version of that. The NHS doesn't pay for everything. At the moment, that rationing does happen, but it happens on the shop floor because we've got massive waiting lists. The NHS is an insurer, right? We don't like to think about it as an insurer, but it is. Both an insurer and a provider. It's the biggest ACO going. But if you went into any insurer in the world, you would find rooms and rooms of actuaries trying to balance their assets and their liabilities to make sure they don't lose money hand over fist. But we don't do that in the NHS. We basically promise almost everything to almost everyone and wonder why they're accused. And then that rationing inevitably happens on the shop floor. And so what I'm saying is we don't need to go down an American route or a Netherlands route or whatever it is, but you do need to find some mechanism to live within your own means. At the moment, we do live within our means, but we do it through rationing on the shop floor. And what I'm saying is if we had a more rational approach to this, where you drew a ring around something and said, look, the NHS can't do everything, but it can do this. You will get an ambulance, you will get a GP appointment, you will get an elective operation, maybe you will get a GLP, but it doesn't do everything. Because otherwise, if you don't put a ring around it, people are going to give up on the whole thing. Wes has even said this. He said at first people will vote with their feet and then they'll vote with their taxes. Now they're already voting with their feet. People are circumnavigating GP services. If you look at young people that got a GP appointment last year, 18 to 24-year-olds, 45% of them saw a private GP. The service doesn't work for them anymore. If you look at people in middle age who are taking out private health insurance increasingly, people of older age who are paying out of pocket for their hip or their knee or their cataract or whatever. So increasingly people are circumnavigating a system that doesn't work for them. If you are offering that level of service and continuing to ask for high rates of taxes, people are going to get fed up. And honestly, I think that is really, really insidious, because we're about to enter an age of AI and whatever, where almost from the moment you're born, your risk of ill health is going to be revealed very, very early. If you lived in a country that had competitive health insurance, that would make a lot of people very quickly uninsurable. So I think we have never needed a socialised health insurance system more than we do now. What I think we need to be really careful about is what is and isn't in that service. The tipping point will come around emergency care, because while people can afford to buy themselves a hip operation or a GP appointment or maybe even private medical insurance, there's no money in the world that's going to get you an ambulance in 7 minutes for a stroke. And if their kid is in front of them having an asthma attack or having a fit and they don't get an ambulance, they're going to start to think, what am I paying for then? So do I think there's enough money? Not for everything. Do I think 200 billion is enough? Yes, I think it is. I think that's about right for a country of our size. But we just need to be much clever about what we're spending it on.
I think you've made a really strong point there. I guess the corollary to that is around the politics of all this, because it's clear that Labour backbenchers feel that the cuts to welfare were morally, in their terms, a step too far, but also politically were a step too far. If you propose the kind of stuff that you're talking about here, which is really saying we will ration the offer of the NHS going forward, that's not exactly going to pile up the votes, particularly in a populist agenda for many political parties, is it?
But we already ration care. And I'm saying we ought to be using the money that we have to spend it on people that can't afford it and asking people who can afford it to pay a bit more. It's in fact what people love about the NHS so much is often its insurer function. It's the fact that you pay according to your means, you take according to your need, and it's free at the point of use. And what I'm arguing for is a better mechanism to retain all of those policies.
Except free at the point of use for some.
OK, well, fair enough. If you can't afford it, it should be free at the point of use.
Let's move on. I really want to touch on the tech issue. What do you think will change most and most radically over the next 10 years?
I think it's going to be autonomy. If you look at stuff like ChatGPT, people are now using it as if it was a doctor. I'm not saying they should, but they are. That is only going to continue to increase. And I think that the biggest thing the NHS could do would be to get out of people's way and let them navigate that new future safely. So I think through the NHS app and things like that, I think autonomy and use of AI.
Can I just ask you to come on a journey with me to one of my favourite hospitals? It's the Bassett Law Hospital. And they won't mind me saying this, I hope, but it is a proper, bog standard district general hospital. And I don't say that in any pejorative way at all. It is what I think all hospitals should be. It's popular in the community. It's the only hospital, so people don't have a great deal of choice. If they're sick, they've got to use that hospital. And it's run by people who know what they're doing. How do we sort out decision support for a junior doctor at the bedside of somebody at 3 o'clock in the morning who needs some help? Where the research is missing, I think, is no one's really researched on the implementation of this stuff. How are we going to do it?
So we've got two different use cases there, because you're looking at an inpatient facility. I don't think we have to reinvent the wheel there, because places like Apollo Hospitals Group in India have already solved this issue. They have this clinical intelligence engine where they've taken all of their patient notes, they've combined it with the most up-to-date medical journals and all of their world-leading physicians, and brought together a clinical intelligence engine that help people make these clinical decisions, and they make it available for doctors to use and for patients to use. So I don't think we are far away from that future. But the place that I'm really interested in it is in primary care and in prevention, because that's the place that it's going to have the most impact. And I have a slight worry with the way that we're looking at primary care, and in particular neighbourhoods. Sort of forgive the way I phrase it with this, but we're just going to design a health system for old people. And that is fine, but they are a portion of the population, and we get really obsessed in health circles because you see sick people all the time, but most people aren't sick, right? You've got 5% of the population driving 40% of cost, and everyone's obsessed with trying to reduce that cost and obsessed with trying to integrate services for that group. But most people walk around every day and they don't ask the NHS for much, right? But if they need an ambulance or they want a GP appointment or if they want to have it there and then, they also need things to help keep them healthy and well and working. And I think we don't do anything for them. I feel funny about using this anecdote, but I will, which is that when I was a GP, you're always worried about the old person who's about to go off legs and the young person that's got a fever. And everybody else in the middle just gets short shrift. And I know that because I gave them short shrift because they're basically well. And they've come in because they've got runner's knee or to get birth control. And nobody's thinking about, oh, how do I help this person who's slightly overweight not become obese and to fall out of the workforce? Or how do I support this person with their drinking? There's a massive gap for people in their midlife and how you help keep them well. And I actually don't think that's best done through GPs because I don't think GPs are very well set up to do it. And I don't think it's what they're interested in either. I think there is a whole section of work that needs to go towards supporting people who are in their sort of working age years to live the healthiest, happiest, most productive lives they can.
But it's nothing to do with the NHS. What can we do in the NHS? Community nurses, maybe occupational health in businesses. We could give people tax breaks for occupational health to make them do that better. We could put messages on the telly.
You know what it needs? It needs a commercial retail offer. And I'm not sure that's going to come out of the NHS, but the NHS can commission it. It's certainly something that needs to happen, right? Everybody knows we're living longer, but spending a greater proportion of that extra time in ill health. And that's a massive drain on the economy. We need mechanisms or structures that can help people live longer, healthier, more productive working lives. They need to be on statins, they need to be on GLP-1s, they need to be on all of these medications that prevent them going on to have cancer or heart attacks or strokes and all these things.
60% of people who pitch up in primary care have got lifestyle-related problems. Secondly, if we look at what they do in Japan, the onus is on the employers to give everybody an annual medical. If you look at what they're doing in Sweden in primary care, but I don't think the NHS can do this. This needs a national wellness service to do this and let the NHS get on with looking after old geezers like Neil Dixon and Roy Lilly and making sure, we get our pills for gout and take our statins. I mean, we're a lost cause by now. I mean, I'm 80. If I live until 90, well, God, I'm going to cost the NHS a bloody fortune. Really, we need to be focusing on the Charlottes of this world.
You touched on autonomy as one of the things that could change. And Roy mentioned within a district hospital getting support for resident doctors and others. And you pointed to the example in India. But how radically could general practice change as a result of not just AI, but of new drugs developing, new things happening that will change the demand for general practice services and the kind of things that they will offer? And I guess the same is true of the acute sector as well. I'm just not getting a feel for, is this a really pivotal point in which health and care services will change?
Good question.
Yes. They will fundamentally change, but in different ways. In primary care, there must be hundreds of software companies knocking on the door of all these GP practices saying, I've got a great piece of software. I can go into your patient records. I'll find all your latent heart disease, all your osteopenia, all of this. And the GPs turn around and go, why would I want to know that? Because they're paid £126 per year per patient, no matter what they do. There is a fundamental problem with incentives in primary care to innovate and to drive prevention. And QOF started to get to some of that, but it didn't really get to the heart of it. And anyway, we don't have that anymore. So I think there is a really strong role for allowing primary care providers, first of all, to specialise a bit and to specialise in different cohorts of the population. And secondly, for there to be meaningful choice between your providers, because I could change from the GP at the top of my road to the GP at the bottom of my road. It doesn't matter. They're all on the same contract. But if they were allowed to do things differently, then they might be able to innovate. So we spoke to a group in the States called One Medical. It was interesting talking to them because they said, we're so big now in Chicago that we've got 3 primary care clinics. I've got one for pediatrics, one for older age people, and one for middle-aged people. And if you've signed your kid up to the pediatric service and they get a fever in the middle of the night, don't call 111, call us. We've got a pediatric nurse on the end of the phone 24/7. If they're sick and you want to bring them in, sure, we've got a bunch of GPs. We've also got a paediatrician around the back. And so they were able to specialise. Now, I'd sign my kid up for that. But at the moment, we're asking GPs to do everything to perpetuate that generalisable model. And it all comes back to the way that you contract. It would be great in the UK if you could have a large-scale provider come along and say, I tell you what, I'll take your hard ones. I'll take your top 2%. I'll take the ones that are spinning the door of A&E and driving up all your costs. I'll look after them. I can't do it for £126 a year. I can do it for £150 a year. But there's no mechanism to do that in primary care at the moment. And I think if we were able to stratify or cohort populations and allow primary care practices at scale to look after different cohorts, to look specifically after children, say, we've got a great paediatric service. We've got a service that looked after children that have learning disabilities, children that have ADHD. People would really go for that. But at the moment, you're still presented with this homogenous primary care offer. And I really think it's all down to the way we're doing the contracting. If you're asking me about tech in primary care, there's loads of stuff that we can do in tech in primary care. But if you haven't got the incentive there to adopt it, then there's no point. So if you think about how industries are disrupted by technology, they are disrupted because of choice, agency and competition. And I know we hate all of those words in the NHS, but it's true. So look at Uber. The fact that Uber was able to overtake black cabs in London, it's very easy for me to move my custom and to not hail a black cab, but actually to use my phone. The NHS is an interesting industry because it's the only industry that has to disrupt itself. Every other industry gets disrupted because people are able to move their custom and everybody has to up their game. And there just isn't that within the NHS. So if you were able to stratify payment for primary care practices, that would go some way to driving that innovation that we desperately need to take up technology. I think it looks a bit different in hospitals, by the way. And if you're looking at things like ambulances, like if you're in a car accident, who wants 5 numbers to ring for an ambulance? There are some things you only want to do once. And I think for them, implementing technology in some of these really core centralised, that you need a body or something that's able to do it. In South Korea, they have a body called Kaidi that really helps try and implement AI at every level in the health system. But at the sort of primary care community level, that element of choice is important.
I used to think that, Charlotte, until I had cancer. So somebody said to me, well, where do you want to go? And I said, I don't know. And I'm somebody who knows the NHS inside out, and I have done for 50 years. So when you sit across the desk and you look at your screen and then you look at the patient and you say, Roy, you've got cancer, mate, where do you want to go? And I live in London. I've got some of the world's best teaching hospitals on my doorstep. I could walk to some fantastic hospitals. I had no idea. Not a clue. I just wanted to go the place that would fix me up. I ended up at Bart's and they fixed me up and I'll be forever grateful. But when it came to choice, no idea.
I understand what you're saying, but I'm not talking about choice from a kind of point by point, where do I go for this condition or that condition or this issue? It's about who do I want to be my GP? If I walked out of here, do I want to be in an OPROS practice or a modality practice or a one medical practice or whatever it is? Not that I want to be given choice at every fork in the road. I'm just saying the big providers of primary care, which will emerge, how do we encourage them to innovate and take up technology? That's the question.
That's a different thing to choice. I agree. Listen, we must move on. Neil.
Just a final point from me, Charlotte, and that is back to the profession. And we've talked to people like Jennifer Dixon and indeed others about the state of the medical profession and the challenges that the medical profession is now facing. Given what we've been talking about in tech terms, as new technologies come in, the nature of professional work tends to change. And you can look in different areas such as the law, where less qualified people are doing more of the work, and those who are more qualified, we may need fewer of them. What's your view about where we're going with the medical profession as a whole? Because if you talk to some leaders of the medical profession, you'd think none of this was going to affect them at all.
I think it's going to be quite profound, the impact on the profession. But I don't think it's a reason to necessarily arm people who have no training with tech and just think they can get on with it. It doesn't matter if you're a nurse or a doctor or a physiotherapist or whatever, but you do need a firm grounding in your clinical knowledge. But I think it will profoundly impact how we practice and how we remain up to date. And who knows how long the whole GP system will last for. one of the interesting effects of it is that it's starting to erode the asymmetry of information that underpins our profession, underpins every profession. And so it becomes easier and cheaper for people to source information and advice from elsewhere. I just think it's going to fundamentally change the way that the system operates and referral pathways and how we use specialists, and probably in ways that we can't really imagine. But what I don't think it's going to do is this dystopian future where we just send out, somebody with an MBQ and an iPad to go and manage really complex patients. I just don't think that's going to happen.
I agree with that, but we're still left with the how, aren't we? The implementation, which is so difficult. The problem is it's not a national health service. It's a loose federation of organisations that all work under the same badge, and it's not even a franchise with an operating model that everybody's got to do the same thing. I mean, somehow or other, if we want to get into this, we really have got to somehow or other put the national back into the National Health Service. Charlotte, I'm really sorry to say time is up. You've been such a good guest and we're enormously grateful, and thank you very much.
Thank you, Charlotte.